Hi, everybody, and welcome to DocTalk. I am Dr. Erin Knopf.
I'm Dr. Corrine Hannon. Welcome. We're going to talk about anorexia today.
All right, start it off.
Okay, so before we address some myths about anorexia, Dr. Knopf, you and I were chatting about how complicated eating disorders are and that they can often start out a little bit differently than they end up. Did you want to comment on that before we get started on
Yeah,
myths?
absolutely. When we think about eating disorders, but I think this shows up so much when we talk about anorexia specific of all of the diagnostic options. What might be its own disorder by the time it's identified and treated really started out as a symptom of something else. It was a symptom of something else underlying, whether that was a need for control, a need to reduce distress, a need to feel, or a compulsion to make different choices, especially when we live in a society where health is moralized so much. That is often the first thing people turn to. If something feels dysfunctional, they feel, well, if I just make healthier choices, then I will find happiness. So it's this pursuit that gets completely hijacked because ultimately, when you subject yourself to nutritional deficits, 35% of people are at risk of developing pathological dieting, and 20 to 25% of those will slip into full blown eating disorders. So it's really important to know that, yes, we're talking about these disorder traits and characteristics, but where it stems from is ultimately what we as providers try to get to. What was going on for you before the onset of your condition that really needs to be resolved for you to find peace in your life?
Well said. And in order to treat any eating disorder, we first focus on stabilization of behaviors, eating disorder behaviors, and then get to the core issues. So let's jump into some myths about anorexia. I think the very number one myth about all eating disorders is that they have a look. And then specifically with anorexia, that people with anorexia look a certain way. A big problem with this is because the DSM, which is the Diagnostic and Statistical Manual of Mental Disorders, has had multiple iterations and has evolved in how it talks about eating disorders. It's gotten better, but we're not there yet. The current iteration of the DSM-5 has removed a very specific body type from the diagnosis of anorexia, but it still has weight bias about like thinness being one of the diagnostic criteria. And Dr. Knopf and I are going to be talking in a separate webinar here about what's called atypical anorexia, and some of the weight bias and weight stigmas that are associated, like medically as well as culturally, in terms of thinking that anorexia has a specific look. So anorexia does not only occur in thin bodies or bodies that are under their body's preferred weight. It can happen at any weight status, but we're going to talk more about that, specifically how it's problematic to make it about thinness in another webinar. I also want to just dispel the myth that it only, like there used to be a myth that was perpetuated in my education that people with that anorexia only occurred in like wealthy white women in Western society. That is absolutely not true. It's around the world. It's global. It does not discriminate gender, sex, socioeconomic status, sexual orientation, ethnicity, race. Everyone across the world, unfortunately, can be diagnosed with anorexia.
If anything,
Another
all that makes me think of is it doesn't just happen in the W's, wealthy, white, women, Western.
Western. Yeah, exactly. Um, Also, there is a myth that males don't get eating disorders or don't get anorexia specifically, and that is an absolute myth. Unfortunately, this is another category where we're achieving equality, but not the kind of equality that we want. At least 1/3 of cases of anorexia nervosa are male or
What's
non-binary.
interesting
Go
too
ahead.
about that statistic is we also recognize that historically, the data collection has been limited because people didn't know how to ask the right questions. They would
Exactly.
ask, very standard questions that would fit one demographic but not the other, and so then would exclude people from those numbers. Now, I think the estimates are getting even higher, where it might even be 40% of cases are male, is what I read. So this is something that I think will continue to evolve as we get better and more specific and precise about how we poll the general population.
Yes. Oh my gosh. Yes. Like commonality in language, diagnostic criteria, research are big problems with getting good data on eating disorders. That
Hmm.
continues to be the case. Another myth is that athletes aren't susceptible to eating disorders. They're just like training, and like athletes are one of the most susceptible groups to eating disorders. A very significant portion of any eating disorder treatment team's caseload is going to be athletes. They're very susceptible because of lots of hyper focus on their diet and on their bodies and on their performance. It makes them very vulnerable to this illness.
Absolutely.
Another thing that is a myth is that it's quote unquote normal or not a problem if you, for example, skip periods or have things like your hair fall out or your nails breaking or feel cold a lot or bruise a lot. None of that is normal. None of that is
No.
acceptable. None of that is sustainable. None of that is recommended. Those are all signs of malnutrition, restriction, and illness. You're the medical doctor
Exactly.
here. Anything you want to add to that?
Oh my gosh. Well, it really is your body's way of communicating distress, that
Yeah.
biologically processes are not working. The building blocks needed to maintain integrity of these tissue structures is lacking. And so these are symptoms of biological breakdown. These are not just acceptable sequela of, living life. Absolutely not. These are problems. And there
Yeah.
might even be hormonal issues at play. We know how devastating anorexia can be to your hypothalamus, to your thyroid gland, to your pituitary gland. All of these components work in collaboration to maintain homeostasis in the body. So again, there's nothing normal about these symptoms showing up.
Well said. One of the comparisons with eating disorders or anorexia that I like to use is a comparison with cancer. Because when you get diagnosed with cancer, people know pretty well that that can mean various things. It can be very complicated, but that it's serious and we got to get treating it. And so another myth about anorexia is that it's a phase that maybe a youth or an athlete or somebody's going through and they can grow out of it without treatment. That's a very dangerous myth of misinformation, because you wouldn't say that about like, oh, they just have a little bit of cancer, just they'll get over it. Like you would just
Can you
never
imagine?
interact. What?
Can you imagine?
No,
That's just
exactly.
bananas.
Exactly. It's very bananas. So I like to use that metaphor because I take it very seriously and we got to treat it and we got to treat it now. And it's not a phase, and you would not take that risk with cancer. And I never would recommend you take that risk with any sort of disordered eating or eating concerns either. Another
I
myth
think that
about
just
anorexia. Oh, go ahead.
illustrates. Sorry, I think there might be a delay on my side. I think the that just continues to display the stigma that exists around mental illnesses and how it really is relegated to this, is that important for you or is that not a priority? And we wonder why individuals struggle to prioritize health saving interventions by seeking out treatment when society reaffirms it all the time of this is a phase, it'll pass, it'll get better on its own, or it
Or
can be
praise
solved
it.
with willpower.
Yeah.
Yeah,
Or they
that's just
praise
not
it
the
and they're
case.
like, good for you. Good for you for
Yeah,
going through a period of starvation. No, it's not good.
not
Yeah,
good.
that addresses another myth, that anorexia can be solved with a willpower to eat. I always tell my clients, if it were as simple as just eat, you would have figured that out by now. And it's deeply insulting for people to kind of make some little tiny comment, like you wouldn't tell somebody with depression to just cheer up, and you wouldn't tell someone with an anxiety
People
disorder.
do.
Yeah, they do, unfortunately, but it doesn't help. It doesn't help. It's the opposite of helpful. So you don't tell someone with an eating disorder, specifically an anorexia nervosa type eating disorder, to just eat. That's very, very dismissive of how complex, difficult, and devastating of a disorder and disease this is. Um,
And we will make sure to give specific tips on how to support someone going through an eating disorder in a later webinar. So don't worry, we will help give you tools, scripts, all the things to do this better and causing less harm for the person you love.
yes. Okay, the last myth I'll mention is that teens and adults, you can think about their nutritional needs in the same way. And I just have a little personal story about this. When my son was being prescribed some medication that affected his appetite and made his weight regress and go back to he was a 14-year-old at the time. And when they prescribed this medication, I was watching him and I was watching his growth charts, and he went back to a weight that he was when he was 11 years old. And I was very concerned and had been talking to the pediatrician and saying, like, I'm really worried about this weight loss. I'm worried about these weight changes. I'm worried about his appetite. I'm worried this medication is not help, even though it's helping him in some ways, the devastating effect of weight loss on a teenager is really concerning me. And the pediatrician was like, well, he's, probably just doing more active stuff. And he just really downplayed my concerns. And as a pediatrician, I'd love for you to comment on that, Dr. Knopf. I was
Yeah.
upset and brought it to his attention enough. He finally realized that this was significant and we changed meds, but I don't think a child is going to be benefited if pediatricians don't take that seriously. And it shouldn't have to be that their mother is an eating disorder expert to notice that. And so I'd love to have you chime in on that if you'd be willing.
Yeah. I think what is really apparent is we do have this moralization of health strictly around weight loss, infiltrating the medical system and then bleeding through that, oh, if it's okay in adult medicine, surely it's applicable to medicine for children and adolescents. But ultimately, they are developing humans. Their bodies work completely differently. Their metabolism works differently for different processes. And frankly, I am of the opinion that lost weight in a child is never good, especially if it's not something that was intentionally being watched for or known to be a possible outcome of a treatment. Again, I don't want to speak for all medical conditions, but ultimately, when you take away weight from a child, you are subtracting the substrate that's needed to help support development. And that is not going to benefit the individual. Aside from all the data that proves that one of the predisposing factors for developing an eating disorder is intentional weight loss or even unintentional weight loss of a certain amount, that to me says enough that the child's brain cannot be afflicted by weight loss safely. There is a huge risk of other complications coming from it. So yeah, that would be very concerning for me, especially when you're talking about 14 to 11 developmentally. One is a little more prepubescent versus 14-year-old, you're more pubescent. And guess what? Your weight should not be the same between 11 and 14. So if you had regression, that is significant, but you and I could talk about that forever, I'm
Yeah, well,
sure.
I just appreciate it. I wish you were America's pediatrician because clearly a lot of pediatricians didn't get the memo. Mama was watching out for him, but I really appreciate you saying that kiddos need to be gaining weight. They need to be growing, and we need to pay really careful attention to not kind of perpetuate messages that weight loss is in any way, shape, or form always a good thing, and especially in children and teens. So,
Absolutely.
okay, let's
And
move to the
I
next
would
slide.
even add, just in case someone is a pediatrician out there listening and they're concerned about medical complications associated with a larger size, I would still say really consider what you're suggesting, that weight loss is the answer when ultimately maybe we're looking at weight maintenance if
Yes.
there is a concern. But again, that is so individualized. There's no way I can make one blanket statement today. So
Precisely.
yes, we'll save that for another time.
And the importance
So
of working on the relationship with food and body versus trying to change a body in the short term. Okay. Um, all
exactly.
right. I
Well
like
said.
this slide a lot because it shows some of the components of most eating disorders. And I like to talk about eating disorders developing as these very, very complex interactions of ingredients. And I like to kind of talk about it like eating disorder stew. And a lot of us just kind of come on the scene with lots of elements of the stew in our brains, in our families, in our cultures. and that get reinforced in our families, get reinforced from our brains, get reinforced from our cultures. And so when I treat eating disorders of all diagnostic categories, these are some of the very, very common underlying components of eating disorders too. And then I say, and then culture or family, they light the burner and light the match, and boom, we start bubbling. And here we have an eating disorder, or we have anorexia. Being the thinnest is definitely a component of what the desire between almost every eating disorder that I hear about is this desire to be thin or be perceived as thin and get the social capital associated in our society currently. Let me just emphasize currently, because that's not always been the case in human society, that being the thinnest had moral superiority. But another very common component is going to be being the sickest. That one's not up there, but I hear that specifically with this diagnosis. There is such a drive to be as perceived as sick as possible, and that they also don't feel often like they deserve care and treatment unless they have achieved the sickest possible state that they feel like they should. And I really try to nip that in the bud, because like I said with the cancer metaphor, it will not help anyone to keep a tumor growing, getting bigger, getting more malignant, spreading to other organs in the body. How does that help anyone to become as sick as possible before getting treatment?
And if anything, too, it also adds to the prognosis changes, right? If you're catching something early, your prognosis is better.
Yes.
The consequences of fighting a disease are limited if you're doing earlier interventions. If you are waiting, you're just having prolonged damage happening across your entire body, because anorexia does affect every single tissue line in the body. And I should just say, actually, any weaponization of nutrition, whether it's in anorexia or any other diagnosis, affects every tissue line.
Well
Whether
said.
you see it, feel it, or not, it is happening. So ultimately, if your goal is to protect your health, preserve your longevity of life, delaying care is the exact opposite of that.
Exactly. Really well said. And to just one more thing about this metaphor that I use with cancer is that in describing to people how to get treatment for eating disorders or treatment for anorexia, the multidisciplinary treatment is key. Just like with, I mean, I'm not an oncologist, obviously, I'm not an expert on cancer, but just from my familiarity with cancer, that it's often the treatment's going to be like a lumpectomy, radiation, chemotherapy, ongoing medication, multiple courses of action. And the same,
Therapy.
yes, the same is true with eating disorders, that you're meeting with a dietitian, you're meeting with a psychiatrist, you're meeting with a therapist, group therapy, ongoing medical care. All of those things are the best course of making sure that this goes away and stays away, similar to cancer. And the earlier, the better. And the prognosis in the research is that the earlier you get treatment, the more quickly you can recover and stay recovered. Okay, so I'm not going to read all of these little tabs, but I want to just say, will you go back for one more second? Sorry.
Oh, absolutely.
Yeah, so I love just all of these components are very, very common elements of anorexia. And I would add that a very common underlying element is just the fear of abandonment or rejection or not getting love and acceptance. That there feels like it's a diseased way of thinking, but that if they keep their bodies very small, if they keep themselves very small, if they keep their needs small, or whatever small means to them, personality, opinions, muted, quiet, small, that maybe they won't get rejected, that they'll get love. So underlying it all is like, please love me. And this is kind of one of the distorted ways that shows up.
If
Okay.
anything, that makes me think about another underlying, component. This is really common as a reaction to trauma. If
Yes.
someone's been traumatized and violated, there is this survival mechanism that kicks in where it's like they want to just disappear. And if you don't take up space, then you can't be violated or victimized as much. There's kind of this distorted relationship between those. And I think that can make it really hard for someone to find peace, right? If all you're thinking about is escaping and dissolving away from this planet.
Beautifully said. And I would say, an extension of that is also the trauma often of being in a society that tells you how to be, like, for yeah, that there's also systemic and societal trauma, for example, of like what it means to be a woman in society, and that looks a certain way, that acts a certain way, that thinks a certain way, that speaks a certain way, and that's also very traumatic and part of the underlying cause. So let's move to the
Totally.
next slide.
Yeah.
I'm going to talk
So
very,
like with all, oh, go ahead.
well,
You
I
go
was going
ahead.
to say this slide, I'm just going to be very briefly talk about these components of that anorexia is characterized by distorted body images and a very, very intense fear of getting fat or having fat on your body. And it's causes people to really obsess about food and what they weigh or the size and shape of their body, and obsess about what people might think about their body, trying to control their body. It's very dangerous. It's expensive to treat. It's difficult to treat, very, very difficult to treat. And medical treatment may be required for all of the very complicated risks and behaviors associated with anorexia. Talk therapy can really help. It's one of those things, like when we're talking about chemotherapy, radiation, talk therapy is essential. So is dietetic intervention. And symptoms may include trying to maintain a weight that is below what your body prefers or where your body feels safe. But that may or may not actually be the case. And through starvation and restriction, that's one of the hallmarks, and or compulsive exercise. It's also very high risk in families. It runs in families and has a higher. I attended a training that said that the risk of developing an eating disorder, if someone in your family has an eating disorder, is a higher percentage than developing breast cancer if someone in your family has breast cancer. And I've never been screened for eating disorders in my family. I've certainly been screened for cancer. So I think that's something that our medical community could also start adopting. Did you want to talk
Absolutely.
about
If
body
anything,
dysmorphia? Oh, sorry. Go
I
ahead.
do. No, I do. If to go back to, shifts that I luckily have seen in training, from when I was a young medical student to now, there is more emphasis on really ensuring you are asking, because you won't know unless you ask, about eating disorder history, eating disorder thoughts, perceptions, because that statistic of having a higher chance of developing an eating disorder if it is occurring in your family makes so much sense, because this isn't just genetic. This is modeled. This is cultural. This is systemic. There's so many layers that make the pursuit of thinner bodies feel more validated and bona fide as a pursuit in life. Um, so I think I am grateful at least that more providers are getting trained, because I do think that'll help with our overall prevention moving forward. But definitely, let's talk about body dysmorphia, because especially here, we're talking about body image. Really, this is a perception of weight and appearance that is distorted. And people, again, might say this is all in your head, it's fake. Well, we have data that shows that with progression of eating disorders, there are changes in the parietal lobe where this visual representation gets altered. Again, body dysmorphia, or seeing your body inaccurately from how it occurs in life, is not a problem with your eyeballs or your optic nerve or your occipital lobe. It's where the image is processed and given meaning that is affected. So what I often say to patients, it would be a lot funnier if your delusional process was seeing green fairies, because you at least can know that in real life, green fairies are not around. They're not, normal. So, and it could also be less threatening, right? But when you only see something distorted, looking at yourself, and then you also have the internalized messages about this characteristic being unfavorable in society, of course it's going to cause distress and dysphoria. I always want to make clear body dysmorphia is different than body dysphoria, where that is strictly focusing on the emotional reaction to one's body. But body dysmorphia is very real. It extends beyond anorexia, but certainly is a really notable characteristic of those struggling with anorexia.
Thank you. Okay, let's talk briefly about some of the dynamics that manifest pretty regularly with anorexia. The hallmark feature of anorexia is restriction. And restriction can happen mentally, but it can also happen like physically or physiologically. And there's three ways of restricting energy intake, because I often have clients with anorexia that they say, oh no, I'm eating. And yes, okay, of course you are. You can't last long without eating some, but you can restrict the timing of how you're eating, how often you're eating. You can resist the amount of what you're eating, and you can restrict the types of food you're eating. So treatment for anorexia involves non-restriction in timing, amount, and type of food. And you have to do that at a pace that works for the client, and that requires a team. But restriction is a really hallmark feature of anorexia. Another one is fear. Fear is another hallmark feature of anorexia. Fear of body changes, fear of food, fear of people judging or thinking things about their body, or fear of abandonment. Like those are really big hallmarks. It's kind of a phobic type manifestation around food and things that people without an eating disorder would consider not very, very frightening at all. And it's also a disorder of distortion, distorting, like cognitive distortions. That's what I mean about when I can hear people with eating disorders, the way that they talk about food, the way they talk about their bodies, the way they talk about their relationship with movement. They're distorted, they're unwell, they're sick, lots of sick thoughts. And I can hear those as a trained clinician. And those are probably the three main ways that you'll see this dynamic: restriction, fear, and distortion.
Something we want to mention too, when someone is either in the process of getting diagnosed or has been diagnosed, there are certain qualifiers that the DSM-5 says are mandatory as far as like, is this restricting type or binge purge type? And ultimately, there is some specificity that can be gleaned from having those added types included in the diagnosis. But ultimately, in practice, and I'm curious what your thoughts are, Dr. Hannon, in practice, I still see that being less of a necessity in treatment, because ultimately, as you named, those are still two different ways that someone is interfering with their nutritional energy intake. It is still causing medical sequela in both conditions. It is severe in both conditions, and patients often swap behaviors, especially once they start treatment. If they're trying to interrupt restriction, they are more likely to engage in other compensatory behaviors to, again, limit their nutritional intake. Maybe that's starting, to exercise more frequently, or they are feeling the need, well, I guess I'll try eating this, but I'm going to purge afterwards. These are all different ways that someone can still be anorexic and these behaviors can show up. So ultimately, yes, it can add some, but I wouldn't say it's so significant as we've been led to
it's all
think, or as
variations
we
on
were
a
taught.
theme. It's all variations on a
Correct.
theme, which is
Correct.
disordered relationship with food and a distorted and disordered relationship with movement and your body.
Exactly.
Okay,
So
so go ahead.
I think, in general, in these seminars, we're wanting to really give people an opportunity to think, how do I know if I or someone I love is struggling with this? And so some questions to consider and some signs to consider, are, do you, other than the behavior around the food itself, what physical symptoms might be showing up for you? And we see temperature dysregulation. So someone might be very cold, someone might not be able to warm themselves effectively, the constant fatigue, or the inability to change positions without experiencing dizziness, or stars in your vision. These are all some early signs of malnutrition. I'm curious, what do you find most patients complain about, or a lot of patients complain about
So
when they're
yeah,
meeting with you and you're
a few more
assessing?
things to watch for include significant weight changes, color, like mottled blue skin on hands and feet from the temperature dysregulation, sometimes yellowed teeth or enamel problems from like vomiting. That's also consistent with bulimia, which we'll talk about more later. Anemia, menstrual problems, irregularities, clearly anxiety around food, Indications of malnutrition, we've already talked about, like hair loss, chronic illnesses, brittle nails, bruising. Lots of bruising is another one that I talk to people about. Do people comment or think about their appearance, food a lot, obsessively, repetitively? How much of the day are they obsessing and thinking about food in their body? And then are they anxious, withdrawn, depressed, or otherwise psychologically different from prior functioning? Those are some things to kind of think about if you or a loved one think you might be struggling.
And if anything, hearing that list, you're right, there are overlaps with other disorders. And, this is to just add that emphasis that anorexia would need to be on the differential. I think the biggest part that distinguishes anorexia from other diagnoses is recent weight loss. So if you or someone has lost weight recently, and now you have these other findings included, really, really pay attention to your gut that there's something wrong here. Ultimately, any significant weight loss in a short period of time can create malnutrition in an individual, regardless of the starting weight state. So again, to really nail it home, this happens in all bodies, small bodies, larger bodies, it doesn't matter. So if you or someone has lost a significant amount of weight, try to look past the positive reinforcements that others might be talking about or praising and really pay attention to, are there any signs of consequences of this change in status?
Okay. So really quickly, because we're running out of time here, but anorexia is a self-reinforcing dysfunctional cycle. That's one of the reasons it's very difficult to treat. I was taught to call it an ego-syntonic disorder, meaning that the patients who have these symptoms, they like a lot of the results or consequences of these symptoms. They like engaging in the behavioral symptoms of this eating disorder. And that makes it really hard to get the motivation to come out of them. Whereas some of the other disorders, there's like more ego dystonic feelings where they hate it and they want to stop it and they're very motivated to recover. Anorexia, sometimes there's a lot of difficulty with motivation. And so that's one of the things, that this becomes a self-reinforcing, dysfunctional, difficult cycle to treat, but it is treatable. And recovery and complete recovery is possible, but it's complicated, just like cancer, and it depends on a lot of factors: how good of a treatment, how early, and how thorough. Last thing we'll say, we have one more slide really quick after this, but anorexia really is based on a perception of weight and appearance. So in order to treat anorexia or any other eating disorder, we also have to treat all the underlying dysfunctional belief systems that have led into reinforcing, for example, anti-fatness, or just like a very narrowly defined definition of what it means to be beautiful or desirable or attractive. So we're going to be talking in these seminars about unlearning anti-fatness and unlearning toxic beauty culture, or featureism. For our last slide, this is going to be very similar to what we talk about with every one of these diagnoses, where it's very individual and unique, but there's also so many themes that unite all these diagnoses. And if your body weight is changing significantly, you need to be treated, and you need some help, and talk to your medical team to determine your risk. And the best multidisciplinary treatment, as stated, is going to be a physician, psychiatrist, psychotherapist, dietitian, and a group therapy treatment. And those thorough assessments can also rule out hormonal, chemical, or biological influences that may continue to contribute to this behavior. Anything else you'd add, Dr. Knopf?
No, that was amazing, Dr. Hannon. That was so thorough. And thank you, everyone, for joining us. We will see you next time on DocTalk.
Thank you. Bye-bye.